Hi, good afternoon, everyone. If you're brave, feel free to turn on your cameras and give me a wave. I know folks are just jumping on. Thanks for spending your afternoon with us. On the behalf of the New England Mental Health Technology Transfer Center's Early Psychosis Learning Collaborative, I am super excited to welcome all of you to the 7th of our series of online discussions on implementing real-world evidence-based services for early psychosis and clinical high risk for psychosis. Today's discussion is about the challenges of developing a psychosis-savvy behavioral health workforce across the state with Dr. Margaret Geyer, who's the Director of Workforce Development at the Massachusetts Department of Mental Health. If you haven't already, please take a moment to introduce yourselves by typing into the chat box. Let us know where you're tuning in from and joining us from today. My name is Michelle Friedman-Yakubian, and I'm a clinical psychologist and early psychosis trainer for the New England Mental Health Technology Transfer Center. I'm also the director of CEDAR, a coordinated specialty clinic for youth at clinical high risk for psychosis in Boston. Or since March of this year, it's been a completely virtual clinic in which I operate out of this room in my home in Cambridge, Massachusetts. The goal of this series is to bring together leaders, clinicians, administrators, and other stakeholders who are interested in working together to increase feasibility and scalability of specialized early psychosis and clinical high risk for psychosis treatment. The format of each discussion in the series includes a 30-minute presentation or interview with an invited expert, followed by 30 minutes of questions and discussion by participants. We really hope you'll choose to keep your cameras on today and to participate actively in the discussion. It's our hope that some of you will use these discussions as a chance to network with each other, develop working groups, and to try out strategies that we discuss in order to advance important initiatives that will make high-quality coordinated specialty care accessible to young people and families that need it. During the discussion part today, you'll be able to participate either by turning on your cameras and mic and speaking directly, or if you'd rather, you can type questions right into the chat, and I'll be looking out for those as well. I've noticed it's really nicer and more lively when folks do turn their cameras on and let go of shyness. So if you're willing, we'd love to see you. And right now, I'm gonna turn things over to my colleague, Rachel, who's gonna just share some information, housekeeping information, as well as some information about the MHTTC. Thanks, Rachel.
Next slide, please. Hi, everyone. This is Rachel, the project coordinator for our Early Psychosis Learning Collaborative. I just wanted to review a few housekeeping items with you all before we begin. Participant microphones will be muted at entry, and you'll be able to unmute them during the discussion portion. During this presentation, if you have any technical difficulties or questions about the topics, please use the chat or the raise hand feature during the discussion to have your microphone unmuted. And this discussion is being recorded and will be available for viewing at a later time on the MHTTC website. And to reach us after the webinar, you can email newengland@mhttcnetwork.org. Next slide, please. So our MHTTC's mission is to use evidence-based means to disseminate evidence-based practices across New England. Our area of focus is geared towards recovery through recovery-oriented practices and support services within the context of recovery-oriented systems of care. Next slide, please. To ensure the responsiveness of our work, we will actively develop and maintain a network composed of different stakeholders from each of the 6 states to guide our activities. And then with that, it is my pleasure to hand it back over to Dr. Michelle Friedman-Yakubian for introductions.
Hi again, everybody. I am back. So before I introduce our wonderful presenter today, we have a quick poll question for folks, if they wouldn't mind. I think Vanessa is gonna unleash the poll just to kind of get a sense of who we're chatting with. Awesome. Looks like we've got a mix of clinicians, researchers, administrators, and policymakers in this group. Awesome, great. Well, maybe I'll leave that up while I introduce our speaker. So it is my pleasure today to introduce Margaret Geyer. She's going to lead a very timely and important discussion on the challenges of developing a psychosis-savvy workforce across the state. Dr. Margaret Geyer is the Director of Workforce Development at the Massachusetts Department of Mental Health and is the Director of the department's Early Psychosis Initiative. She is responsible for the identification, evaluation, and dissemination of evidence-based practices within the Department of Mental Health and among community providers. Dr. Geyer is a clinician and researcher who has worked with people with severe mental illness for more than 20 years. I have also had the pleasure of working with and getting to know Dr. Geyer over the span of quite a few years, dating back to when I was a graduate student starting out in this area. Margaret has been a tremendous advocate for early intervention for psychosis in Massachusetts, and she has been creative and strategic in using limited resources to expand access to high-quality, coordinated specialty care for early psychosis across the state. So rather than using a PowerPoint presentation, today's discussion is going to be a little more informal. That is, I'll be asking Margaret to tell us about the work that she has implemented and observed over the past 20 years in our state. So it's my pleasure to introduce Dr. Margaret Geyer. Sorry, Margaret, looks like you are still muted.
There we go.
Great. Awesome.
Thank you, Michelle. And thank you, everyone who's here today. It's really a pleasure. I'll be able to see you better in a little bit, but I'm really looking forward to the conversation that we can all have together about how to do this really hard work together.
Thank you so much for being willing to do this. It's such a pleasure to have you on today. So what we thought it's kind of fun getting ready for this discussion because we kind of took a little trip down memory lane, kind of thinking about the landscape and kind of what things were like kind of when you first started doing this work. And so what I'm going to do is just kind of ask you some questions to maybe set the stage for sharing with folks what's happened in Massachusetts. And along the way, we'll love to hear people's thoughts as well about any creative things that they've noticed in their state about how early psychosis work has been disseminated. So Margaret, to start us off, I'd love to hear your thoughts and observations about what was available in Massachusetts for early psychosis when you were kind of first starting out in this work, what the landscape looked like.
Sure. So the history of early psychosis work in Massachusetts is more than 20 years old. And when I first arrived on the scene about 20 years ago, really for the first 10 years, early psychosis work originated with our research partners, our academic centers. And I was thinking as I was preparing for today, Massachusetts is a tiny little state in the Northeast. We have a big ego, we know that. And so I just want to acknowledge that. And I feel a lot of pride about what we as a tiny little state have been able to do over these 20 years. And I think that many of you who've been part of the national scene for a while may know that Larry Seidman was a really important figure for all of us in Massachusetts, and I think for many of us nationally and internationally in early psychosis work. And so I had the pleasure as a clinical psychologist in training to learn from Larry and then subsequently to work with Larry. And he really, to my mind, very early on set forth the basic tenets of what we need as a community and a state in order to really bring early psychosis to the forefront of people's attention, and so that it gets the services and resources that are needed. And you know, that it's a really easy list, but it's a really hard list to do. And one of the things I want to say about Larry also is that he, like many of us in Massachusetts, really put patients first. And so I think very much from the beginning, and part of what interweaves a lot of the way that we operate in Massachusetts is wanting to partner with people with lived experience right from the get-go. And so what does that mean? When, you know, early on, what early psychosis looked like in Massachusetts was academic centers partnering with clinics and community settings. So that's been a critical piece of what has made early psychosis work possible in Massachusetts. Part of what comes with academic centers and clinics partnering is that you get trainees. And so one of our strategies in Massachusetts has always been to really privilege the training experience, because we're raising up future practitioners. So when you ask, how do you grow a behavioral health workforce, we have to start early and really support people as high school students, as college students, as graduate students, and getting exposed and having an opportunity to really work and to catch the fever. Most people who do early psychosis work do it because they're passionate about it and they have a sense of mission, and we want to instill that early on. I think the other piece, there were two other pieces that really sort of emerged, I think, from sort of Larry's masterful kind of vision of how to do this. And one was what we ultimately called sort of the prevention collaborative, but was, in addition to partnering with people with lived experience, you want teachers, school administrators, college administrators, primary care doctors, you want your community stakeholders at the table, because they're sort of the gatekeepers or the early detectors. They're the people that folks turn to when they don't know what's going on, but something confusing is going on. And so we really convened that community group to help kind of raise awareness and spread the word. I think that's a good start for now.
Thanks, Margaret. There's so much in there, and certainly brings up a lot of that really resonates with me and how I got started in this early psychosis work as well. I'm definitely somebody who was very closely mentored by Larry Seidman over the years. And I remember my first entry into early psychosis work was as a trainee, an intern at the Massachusetts Mental Health Center in Boston, and was given the opportunity to be part of, you know, one of the first early psychosis programs in the area, the PrEP program. And that definitely rings true in terms of how trainees, and there's a number of folks even on this call who have started out in early psychosis work as a trainee as well, and that training mission being an important part of that as well. So Margaret, can you tell us a little bit about your role at the Department of Mental Health and some of the goals that you had for this work when you were kind of first taking on the mission of expanding early psychosis services across Massachusetts?
Sure. So my role within the Department of Mental Health as a clinical psychologist is really to help disseminate high quality evidence-based practices, both in the work that we do as a department, and then to really support that dissemination among community providers. And so really and truly, when we got the first 5% of the mental health block grant set aside dollars, the first thing that we thought about is, so Massachusetts is small, and even though we're small, pretty much everything gets concentrated in Boston. And then there's another 150 miles of expanse where not a lot happens. And so I was asked, when we got the 5%, I think people who were involved on the call at that time know that we got it and we had to have spent it already before it even arrived. So one of the very first things that we did was establish, we had a program in Metro Boston that was state funded and DMH operated. It was a really robust early psychosis program that emerged out of the partnership with Larry Seidman's group at the Beth Israel Deaconess and a DMH operated outpatient clinic. So when we got the first 5% from the mental health block grant, we went west and we established a second first episode psychosis program out in Western Mass, which serves the other half of our state population. And we were really interested in replicating, sort of testing whether the program we had in Metro Boston that was born of academic experts and passionate crusaders, whether we could sort of seed that in a new part of the state that didn't have any of those early roots. And I'm happy to say that that program has really taken off and benefited from the mentorship and clinical leadership that the folks in Boston were able to offer to that program. So that's a very exciting part of it. And what we did with that second program is we basically said, you have to have an academic partner, you have to have trainees, you have to have a way of getting feedback from your youth and the families served so that your programming is constantly sort of being responsive to the people that you're serving. And one of the other things that we've done here in Massachusetts, I think really in concert with what's happening on the national scene, is we established early on a standardized clinical assessment battery. And our motivation was multifold. One primary reason early on for having a standardized assessment battery is many of us passionately believe this work is important and valuable, but we also know that we need to sort of demonstrate its impact, that it is in fact changing people's lives, that youth are getting back to school, working, staying out of the hospital, maintaining themselves in homes instead of homelessness, reducing, we had all of the sort of classic outcomes that we're all concerned about were part of our assessment battery, because we know it's not easy to get this service paid for. So we're fortunate we have state dollars, we're fortunate that we have federal dollars, but the third-party reimbursement rates for the services that we provide don't come close to paying for the service itself. And so we wanted to be part of establishing an evidence base so that we could make the argument for the services to be delivered. And so that was, all of that was built into our second kind of program in Western Mass.
Mm-hmm. So that was a really important initiative in our state, because once Prep West opened up and started, then at least there was the entire state, even though it might not have been conveniently covered, that it really kind of hit the part of the state that was least accessible to Boston,
yeah,
in terms of offering these services. And as someone who was connected with the Prep East program, the sort of Boston program, it was a first opportunity to kind of get outside of our little bubble of Boston academia doing this early psychosis work, and also think about how it was getting implemented in another program in another region of the state, and to start to learn from the perspectives of others across the state as well.
Can I ask a question just to clarify, because I don't remember, where is Prep West?
It's in Holyoke.
It's in Holyoke, okay.
Yep.
Okay.
I mean, there's still a lot of the state beyond Holyoke.
Yep.
But yeah. You know, I think
So
some
for
of the,
folks who,
go ahead.
oh, sorry, I was just gonna say, for folks who aren't from Massachusetts, Holyoke is like way on the western end, whereas Boston is way on the eastern end. So they're like as far apart in Massachusetts as just about can be.
Yeah. You know, I was thinking also this morning that actually one of the things that really inspired me, so we were thrilled, to be honest, when the 5% set aside was doubled to 10% set aside. And around that same time, our commissioner, Joan McCullough, recounted a story of having dinner with a colleague and friend who's a neurologist, who basically said, what's wrong with you guys? We know you have all of this evidence-based data and interventions. You know how to treat early psychosis. Why aren't you doing it? And you know, sort of said, it's one of the few illnesses that we actually are pretty good at treating. We know we can make a difference. Why isn't there this sort of groundswell of enthusiasm and resources and commitment to delivering this service when we know it works and we know we can make people's lives better? And so in some sense, I feel like I've been that sort of soldier of, by golly, we have got to get the word out there. We've got to change the fact that, you know, we're borrowing and stealing in order to provide this vital service to people that really changes people's lives. So that's part of what that sort of drives my passion for this. And we have a vision in Massachusetts, I think we're going to get to, that one of the things I'm excited about is we got the 10% set aside funds, and IMH started funding additional research related to early psychosis and implementation of coordinated specialty care and evaluating the impact. You know, there's all kinds of research suddenly really focused on early psychosis. And as someone who was raised up in Western Mass, but has spent most of my adult life in Boston, so I know we're being very colloquial here, but I was very aware that everything tends to just gravitate towards Boston, and that in order for us as a state to be sure that we were reaching everybody, we needed a strategic plan. It couldn't just all sort of reside in everybody just being drawn to Boston and doing all their work in Boston. That we needed as a state to set forth kind of what our vision was, so that when researchers come into our state and want to do research, they're doing research that really helps us further our goals for the people that we're serving here in Massachusetts. And so for the last probably year, we've been embarked on this process of trying to articulate a strategic plan and to engender the involvement of youth who've been served, youth who've not been served, youth who have not found their way to our programs but are living with psychosis, and similarly families who've been served and not served by our coordinated specialty care programs. And so we're sort of starting again with, what do youth and families say they need and want, what has helped them, what has worked, what has not worked, and then how do we sort of have I always think of it as a pyramid. How do we get the whole world aware of what early signs of psychosis might be, and helping send people so that they can get the specialized services and help that they need? How do we get clinicians to not be scared to ask about psychosis? And not just, are you psychotic, but to have meaningful conversations about what people are experiencing and then helping them get connected to specialty care. The two programs that DMH operates with state funds and the mental health block grant funds are coordinated specialty care programs. I describe them always as coordinated specialty care programs on steroids. So we have the core elements of coordinated specialty care, and then in both of those programs, there is what we call oh my goodness, it's what transitional age youth always ask for, a storefront, as opposed to walk into a medical center. So a destigmatizing space that belongs to the youth, that is for the youth and of the youth. They helped decide the paint colors. They help decide the furniture. It is their space. And they connect and learn from each other. And so you have the amazing experience of watching people at different stages of entering into treatment and coping with their illness and welcoming someone who's new and shell-shocked and slowly being introduced into the milieu, able to be in a safe place and able to sort of emerge from their shell and engage with peers. And you have families that get to participate in multifamily groups so that they're connecting with other families who are at various stages of living with this illness and coping with this illness in their family member. And so the beauty of what we're really able to offer each other and everybody is the power of those relationships in really transforming people's experience and their relationship to the illness and to themselves and to their own recovery. That's extraordinarily expensive. And so for now, we're starting with, we have 2 hubs. We have one in Eastern Mass, we have one in Western Mass. Both are affiliated with academic centers, both are training hubs, and both do a huge amount of work talking to college students, college administrators, police, religious leaders, community leaders, primary care doctors, ED docs, getting the word out, both about how to recognize early psychosis and where to send people. So that's kind of our sweet spot. The second tier we think of as our community clinics that are delivering coordinated specialty care. So part of what we've also done is we've provided grants to community clinics that want to do coordinated specialty care, and they can rely on the fee-for-service, third-party reimbursable system to support some of that work. But we rely heavily on, to be honest, Bob Heinsohn's white paper on coordinated specialty care really helped us define the non-billable, unpaid, necessary elements of coordinated specialty care. So we provide grants so that staff can attend team meeting, because apparently team meetings are now radical in behavioral health. 20 years ago, that was the standard. Team meetings, supervision, training. So we're basically buying clinicians time so that they can be trained and supervised and really learn and master evidence-based practices. And we're paying them to implement them with their multidisciplinary team meetings and supervision and some of the collateral care. In Massachusetts, we do not have third-party reimbursement for employment services or peer services, so we use our mental health block grant dollars to basically help community clinics be adherent with the models of coordinated specialty care that have been demonstrated to make a difference in people's lives. So those are 2 of the things that we've done with our mental health block grant. And I have to say, and then I'll stop talking and hopefully get some questions. You know, the third, it's like a stool, right? A third legged, we have 3-legged stools. So we have our PrEP programs, we have our coordinated specialty clinic programs, and then we have what we call our first episode psychosis technical assistance center. And then the stool, we're going to call the stool MAPNET, right? Because that's the whole network. But our technical assistance center is basically, we took the work of Larry Seidman and his team and we blew it up. And so, or not in an explosive, destructive way, in a like expand and be bigger and more marvelous than ever before. And so our technical assistance center provides supervision, organizes learning communities, has public webinars, does a lot of the community education that the PrEP programs also do, provides clinical consultation, and does a huge amount of work creating a community of first episode psychosis clinics and clinicians. I am a psychologist, so I believe in relationships as the way to sort of make things happen. And so in addition to the relationships of youth and families, I think the relationships of clinicians and clinics who are all committed to this work is part of how we are slowly sort of transforming our system here in Massachusetts. And I get accused of being Pollyanna-ish because staff turnover is a huge problem. And so we are constantly training and retraining and retraining. So we just have to have an annual kind of training calendar on the evidence-based practices. But I like to think that people are going on to other clinics and other settings and they're spreading the word. And so it is okay to have staff training as long as we keep them sort of invested in our fold. And that's one of the things our technical assistance center can do. The other, and I'm sorry, because there's so many pieces, this is why we need a strategic plan. We're happy to share a strategic plan with all of you. The other piece that the Technical Assistance Center does is that going back to that standardized assessment battery, they sort of hold this is our standardized assessment battery. They provide a lot of training in utilizing it as a clinical tool so that it's part of treatment planning, it's part of ongoing treatment goals, and sort of feeding back with the youth and the family. Are we helping you? Is this making a difference? Are we working on the things that you would want to be working on? And are we having the impact that we want to have for you in your life? So the Technical Assistance Center is critical to disseminating that as a widespread tool that's in use. And then they collect the data and they analyze the data and they provide ongoing reports to us. So there's a lot that we're doing that is very intentional about trying to create a community that's really invested in implementing and delivering high quality services for folks.
So there was a lot there. If I can do my very best to kind of summarize the highlights of that as well. So we've got kind of the hubs, the main sort of, the programs on steroids in Eastern Mass, right in Boston, as well as in Western Mass. And then there was the MAPNET initiative, Massachusetts Access for Psychosis. Oh, I had it all written down. Now I can't remember. Massachusetts Psychosis Network for Early Treatments. And I included the link to the website for folks that are interested. As well as we've got lots of folks that are on who have been very integrally involved in this work as well, including Emily Klein, who maybe can love to have you say a few words as well. And those programs provided additional assistance for programs that already had an early psychosis program starting in the works, but didn't necessarily have resources for some of the elements of coordinated specialty care, like time for clinicians and team meetings, an assessment battery to look at outcomes. And another thing that I really appreciated that maybe I'll just highlight about that MAPNET initiative was DMH really fostered communication and collaboration between programs that otherwise were working very independently, even in competition with each other, and created a more of a cohesive connection between programs that I think was really, really neat to see. And kind of getting back to what you said about egos of different programs. And I don't know if you have further thoughts or comments on that piece as well.
Yes, and you just did a nice job of distilling out the pieces that I was talking about. So yes, absolutely. I think the bringing the clinics together to learn from each other and brainstorm and strategize has been a really exciting part of the work that we've been doing. And I will say, sort of when COVID struck, I think it was really nice for all of the clinics to have a community of peers. And so we actually quickly organized, like everybody else, kind of Zoom meetings to provide ongoing support and any sort of technical assistance that would be helpful to all of them. I think actually just to name, so one of the issues is that we have really solid programs that have existed for 20 years. And then we have new fledgling programs. And one of the things that we are really working on instead of forging those relationships is that sometimes the programs that have existed longer have more experience doing those comprehensive assessments. So I think about sort of the first intervention for a youth and a family is really having the holding of a multidisciplinary comprehensive assessment to try to understand what's going on. How do I make sense of this? And so we're working on an idea that our kind of hubs and our centers that have existed for a while and have real expertise around that could be more of the front door. And then once they've helped a family sort of understand what's going on, they can do a warm handoff to one of the newer clinics that's implementing, we're using Navigate as kind of the primary sort of model for coordinated specialty care that we're training new clinics and clinicians in. So we can hand someone off with a pretty well-developed formulation about who they are and what would be helpful to them. And we can do that warm handoff because people are we're Massachusetts, we're Boston, we have our Harvard programs, and people gravitate to a Harvard program to get a good assessment and answer to what is going on. And so we're working on then actually being able to provide the services they need in the communities where they reside and live.
So one of the things that you've really alluded to is there's this kind of the group of programs that existed that got the funds to start communicating and training with each other. And then there's a group of new programs, right, that the Massachusetts DMH has really been fostering. Do you want to say a few words just about those programs and the rationale for that? And
Sure. So you asked earlier, and I didn't quite answer the question well, like what was the landscape before the 10% set aside? And so we had at that time, I think 6 first episode psychosis programs in Massachusetts, maybe 7, and there were 5 in Metro Boston, and then 2 that kind of headed west. And they, as you were saying, they all sort of had kind of grown up themselves with independent sort of ways of operating. And so the first round that we did is we brought those clinics together and did a year-long learning collaborative and tried to just introduce folks to the Navigate model and other sort of evidence-based practices so that there was a little bit of coherence, but really that there was more sharing amongst those programs. In the last year and a half, we've taken on sort of what we call cohort 2, which is where we've gone into a region of the state where there's nothing. So most of our work has been just start in Boston and go west on a straight line, and you can find all of the programs. Now we're going north to a region which has had no first episode psychosis services, and we are basically trying to create the enthusiasm and raise up programs in sort of a relatively barren field, I will say. And so that's what we spent the last year doing, and we have worked really closely with the Navigate team and brought in a lot of training, a lot of supervision, and we have 3 clinics that after a year are finally starting to kind of really solidify each of the 3 teams. So that's sort of, I think, the harder challenge is trying to raise it up when no one else has had that sort of flicker of enthusiasm or an idea that they would like to do this. And we sort of come in and try and engender that interest and enthusiasm.
yes.
I just want to acknowledge, I saw Danelle Hupp from Ohio Medical University. I think your webinar back in 2017 was actually sort of the inspiration for our model and our way of thinking, because I saw what Ohio was doing and the I think you call it the best center in terms of sort of sending out clinicians to work in programs and really transmit the clinical knowledge and expertise in order to sort of get a program going. We haven't been able to do that exactly in the way that the folks in Ohio have, but that seemed like such a brilliant way to do it that I still hope we could figure out how to do that.
Oh, great. Hi, sorry, I shut my camera back off because of the bandwidth. As soon as I get fuzzy and get an unstable. But yeah, that's great to hear. Hi, everybody. And hi, Michelle. You came and visited us with Bryn, so.
Yes, that was great fun, and what a wonderful center you guys have as well. And this is one of the things I love about these Zoom calls and discussions, and just the beauty of communication across the country, across state lines, sharing ideas, the ways in which, you know, rather than reinventing the wheel and trying to come up with a brand new way of doing everything on our own, the ways in which communicating with each other and other programs can really spark good things and can make these services more accessible. And so who would have known that that webinar so many years ago would have led to folks in Massachusetts having greater access to early psychosis coordinated specialty care. So.
That's amazing, and I appreciate you sharing that. I'm going to have to take that back. That's awesome. Nice to meet everybody.
Wonderful. So before we open things up for a full-on discussion, Margaret, I wonder if you can say a little bit more about our strategic planning process and kind of the upcoming plans that we have and where things are at. And I just think that would be interesting for folks to hear about.
Yeah, thank you. And I just want to say hi to Michelle West. We're so great to see you. Michelle left us recently, so now I only get to see her on Zoom calls.
Exactly. It's just like I'm still there.
I know, it's lovely.
Michelle West took things even further west in now that she's starting a program in Colorado.
Yes, it is pretty hilarious, my last name in combination with my current location.
So, you know, with our strategic plan, I guess just to say that, you know, as I said, part of it was in response to all of the inquiries we were getting, largely from researchers, and as grant opportunities arose, we wanted to sort of do it more thoughtfully and intentionally instead of just by the seat of our pants, which so often is how we do things. And so we have a survey that's going on right now asking, you know, that's for youth and family members to respond to, and we're trying to reach both people who've, as I said, used some of our first episode psychosis programs, but also people who maybe have not, who have found other ways of living and coping and managing their illness. Because I believe in treatment, but treatment isn't for everybody. And so we want to make sure that we're, if it's a statewide strategic plan, that we're addressing the full breadth of resources and supports that are really helpful and useful to people. You know, I can say, you know, we're really interested. A big piece of it also is part of going back to our commissioner's sort of battle cry, which is we really need payers at the table. So I think some of the other states that have really been so effective have had their Medicaid entity as their partners. And we are, you know, working on that relationship. And I think we have support from from Mass Health, our Medicaid partner, but we have not really worked in sync in the way that it would be nice to be able to do. And so that's a piece of sort of what we're hoping will emerge from the strategic plan, is that more of the payers will be at the table in Massachusetts and really thinking about this. The other thing that I think we're all super conscious of, even more so now, but always, is access. So racial equity and inclusion is a huge issue. And I think, you know, some of the work that I'm doing in response to COVID, we all have a tendency, and forgive me if you're not one of those people, but many of us are the kind of people where we sit where we are and we wait for people to come to us to get help. And we think, well, we've sent out flyers and we've sent out emails and signs, like people should come to us. And so I think that we see some people. We don't see everybody who perhaps could benefit from some form of treatment. And so we're really trying to think about how to actually go to people and go and forge relationships with new communities that have not traditionally sort of relied on our mental health system for help and have found other ways to try to manage, and to see if we can forge sort of new partnerships and relationships and sort of have what we have to offer be more of service and use to a wider breadth of people. So those are some of the elements that are important to us.
Thanks, Margaret, for sharing all that. And I think one piece that's been interesting about the strategic planning process in Massachusetts is it's, you know, our original kickoff discussion meeting was supposed to be in April of this spring. We've had to completely revamp our strategy and our planning with the COVID crisis. And I think it's allowed this process to grow in a different direction, where we've been able to increase some communication with some of our partners around the state via Zoom calls, and our current planning is more of a virtual process as well. That's going to be, perhaps international, participation involved as well. But I sort of appreciate how it's kind of continued and sort of thinking about the strategy and the plan and, world crises as they are come up. And you've been really sort of leading us to think about how to provide the best possible care and priorities in kind of our new era of being that we're all figuring out at the same time.
Yeah. And I just want to acknowledge that Emily Klein is here. She's the director of our Technical Assistance Center, and we would not have been able to do what we've done without her leadership. So Emily, thank you.
Hi, Emily.
Hi, thanks. And it's great to hear it all described. You've said this when I describe it too, but when you say it, it sounds great. It sounds like we really know what we're doing. And I'm double tasking right now. I'm working on my talk for the strategic planning meeting.
Nice.
So I'm in a good headspace.
Yeah. And we would, when we set out the idea that we would like to have a strategic plan, we reached out on the MAPNET listserv, and there are strategic plans, I think, that some of the research centers of excellence have developed, which have been helpful to us, but we didn't find that other states. So if there's anyone here from a state that has one that's sort of more kind of state focused, that would be really lovely. And part of what we've been really trying to do, and I think that was the whole point of the RAISE studies, was how to take early psychosis and make it something that really is accessible in a community setting across our communities, and not sort of the purview of research, academic, medical centers. So our strategic plan is really about that. And I will say that one of my other hats at the Department of Mental Health is suicide prevention work. And so I have stolen everything from the National Strategy for Suicide Prevention and all of the work that has happened on the suicide prevention front. I think they're about a decade or two ahead of where early psychosis is, in terms of just having kind of the groundswell of and sort of mainstream recognition at this point. We have not yet fully succeeded in making psychosis a public health issue. And I think that's one place where we really need to grow. We're trying to bring our public health partners here in Massachusetts to the table on that.
So I'd love to encourage folks to join the conversation. If you feel brave, turn on your cameras and your microphones. If you feel a little bit brave, you can type in some comments and questions into the chat. We've got about 10 minutes just for kind of an open discussion. Any reflections, and I would be very interested in hearing from folks in different states about kind of their reflections on this and how this connects with or is different from what's happened in your own regions.
I have a question. This is Janelle. I was just curious about the role of NAMI as one of your stakeholders in the state. I asked because we consult with Illinois for our first programs as well, and they're giving a presentation. So this is on my brain. It was just yesterday. So they're giving a presentation to their state NAMI. And so they were asking for, what things to highlight. So NAMI recently, I'm on the board here, but NAMI recently revamped their family curriculum, as you probably know. And for the first episode of Psychosis is included as part of the Psychosis section. So I think it was really important messaging to their NAMI that, we need not only your referrals, but we need your voices pushing this forward. Now that you're getting some information, be loud and make noise, and to make sure that, these programs are funded and available. And so that was, one thing that Illinois was hoping to do some work around. And so I was curious with Massachusetts, what their involvement looks like.
That's an excellent question. And they are fabulous. They've been involved. So they're members of the prevention collaborative that I mentioned that Larry Seidman with Kristen Woodbury had established largely around the Metro Boston area. And they work really closely with the Department of Mental Health and are part of our mental health planning council, that sort of sets the priorities for our mental health block grant. And they are part of the sort of stakeholder group that's part of our strategic planning. So I think we can always do more and better with them. And we're hoping that will, through the course of the strategic planning, that we'll be able to do that as well.
Oh, that's great. Thanks.
Sure.
Other questions that folks have for Dr. Geyer?
So I potentially have one. I haven't super formed it in my head, so apologies in advance. So I just moved here to Colorado and am trying to start a clinical high-risk program, and I'm learning a lot about how psychosis programs exist now in Colorado. They do have a combination of first episode programs here, about 8 to 9 right now, that are supported by the SAMHSA state set-aside money, just like in Massachusetts. And they don't, until I got here, don't have any clinical high-risk programs. So I guess I'm thinking about how to more long-term sustained funding for a CHR program out here in Colorado. And I'm curious if you have, thoughts about how that got started in Massachusetts, or, recommendations or anything in that direction.
It's, and I think that, we're a small state, and so that's probably why I'm so much about the relationships. I mean, our clinical high risk work got started because Larry Seidman, again, said this is really important, pay attention. And he caught the ear of 2 leaders within the Department of Mental Health who basically both ponied up with some money to get it started. So that, I think, in some sense, we're Massachusetts, we're very colloquial, right? So it is sort of relationships that help make things happen. I think in some sense, I'd almost turn the question over to Michelle, because I think some of the work that has been happening in the Cedar Clinic is establishing that there is some capacity for third-party reimbursement for those services that can be optimized. So maybe there's a combination, which is what we're trying to do. We're now trying to do in Massachusetts better, which is really providing the seed funding so that similar to early psychosis, it's the team meetings, it's the extra time, it's the hand-holding of families that don't rise to a billable service. It's all the outreach and consulting and sort of managing referrals that's not paid for. So we try to support that. And then, Michelle, do you want to sort of speak to what your experience has been more recently with billable?
Yeah. So, and Michelle West, all this all too well as well from from our experience together through this process. My blood pressure certainly went up a little bit with your question as well, kind of thinking about that. But
Sorry.
one of the things that, and that's also, it's also been one of the questions that's really sparked my interest in hosting this series. So many of our discussions have really focused on how do you negotiate with third-party insurance companies around bundled payment for these important services, because that's ultimately going to be the way to make these programs sustainable over time, is for there to be a clear rationale for what the package of treatments is and how it works and how insurance companies can pay for it. And so we've learned a lot through this series about the ways forward in that area. It's certainly not an easy road, but I've certainly learned a lot more about this area than I did before. And within the Cedar Clinic, in the last couple of years, we wound up partnering and connecting and basically even though we're physically in the same space, or were in the same space before COVID, we've become part of a different clinic organization that's much better designed for being able to bill third-party insurance for the parts that are billable. So prior to our becoming part of the Brookline Center for Community Mental Health, we, as part of the Massachusetts Mental Health Center, we really weren't getting any insurance reimbursement for services, and that's made a big difference. And so with our move to the Brookline Center for Community Mental Health, we've been able to think about how we offer services and the ways in which those do match up with insurance billing. There's many, many, many parts that are not reimbursable. We certainly are not supporting ourselves, but we're doing better than we did 5 years ago.
One really interesting thing I learned when I got here to Colorado is that the FET programs actually were doing bundled service billing to Medicaid up until like a couple months ago, when the state providers or whatever decided that in order to have parity with other medical practices which don't do bundled service billing, apparently they just got rid of it a couple months ago. And I was like, that's the exact opposite direction we want to be coming.
Oh my gosh.
So that was fascinating.
That is really interesting.
Well, I think in some sense, I'm realizing we're sort of coming back to the overarching sort of topic, which is what's the role of the state mental health authority, and how do we use our state and federal funding to really support these kinds of interventions and services. And we've tried really hard to optimize billing. You know, it's sort of like we've got to hold our payers similarly accountable, and to use the state and federal funds for the clinician time and the staff time that's not a billable service, so that we can it's a hybrid model. It's not ideal, and I don't know how long it's sustainable, but that's what we've been able to do now. And then to really use those dollars for people like Emily Klein and Michelle West and Michelle Freeman-Yakubian, who provide such vast clinical knowledge and training skills, so that we're really trying to support people in learning how to do this well. And when you do something well, you feel good about it, and then you want to keep doing it. And so that's part of trying to maintain the motivation of the workforce. If we take care of them, it's hard work. You know, we're talking about the hard work of trying to get people to do it. And part of what is hard is it's really hard working with a youth and a family who's going through psychosis. And so we need to do as much as we can to provide the scaffolding around the clinicians and the staff so that they can do this hard work.
So I'm realizing we are running up against the end of our time. I want to take a moment to not only thank you, Margaret, for your time today and sharing all of this with the group, but also just all of the support of early psychosis programming in Massachusetts that many folks on this call have directly benefited from. And I hope that I just really appreciate all that you've done as well. And I'm sorry to kind of cut off. I think we would have, likely had some more questions and comments. I will let folks know that we'll add some things into this session the recording will become available for everyone that's registered for it. It will be on the MHTTC website. We'll also add some links to some of the white paper, some of the other resources that Margaret and others mentioned as a part of this. So even though we'll be ending our discussion today, I do hope that folks will continue to talk about this work and share ideas. So feel free to reach out to me as a part of this, and we'll look forward to connecting in future events. Thanks, everyone.
Thank you, everyone.